So we are going to discuss the motility disorders in detail. First of all, Achalasia Cardia. We discussed that Achalasia Cardia is the most common hypomotility disorder, and overall this is the most common motility disorder of esophagus. First, what is the meaning of achalasia? You know, the meaning of achalasia means fail to relax. Fail to relax. So question, which structure is not relaxing here? So it is characterized by absence of LES relaxation. So in Achalasia Cardia, what's the problem? It is characterized by absence of LES relaxation. Here there is absence of LES relaxation. LES relaxation. Clear? It is equally common in males and females. Now see the pathophysiology, it's very easy to understand. We discussed that in GIT there are two nerve plexus, one is Auerbach, second is Meissner's, and we discussed that in esophagus there is only one nerve plexus. Which one? There is only Auerbach plexus, there is no Meissner's plexus. Got it? In Auerbach plexus there are two kind of neurons. You know, Auerbach plexus, it is responsible for peristalsis, contraction, relaxation, contraction, relaxation. So in Auerbach plexus two types of neurons are there. One is stimulatory. What is the function of stimulatory neurons? Contraction. And there is presence of inhibitory neurons. What is the function of inhibitory neurons? Relaxation. Now you tell me, there is selective loss of which particular neurons? So here, since there is absence of LES relaxation, so here there is selective loss of inhibitory neurons, obviously in which plexus? Auerbach plexus. So what is the pathophysiology here? It is characterized by, in this case, it is characterized by selective loss of, there is selective loss of inhibitory neurons. Selective loss of inhibitory neurons. Clear? And because of selective loss of these inhibitory neurons, what's the problem? There is absence of LES relaxation. What are the types of achalasia? One is primary and one is secondary. Secondary achalasia is pseudo-achalasia. Why? Because here the manifestations are because of malignancy. So it is secondary to malignancy or secondary to Chagas disease. So what are the types of achalasia? This question is asked frequently. Types. First is primary achalasia. Primary achalasia, and there is secondary achalasia. So it is of two types, primary and secondary. Clear? We discussed according to Chicago classification, three types are there. Type 1, classic. Type 2 was EC, that is esophageal compression, and type 3 was spastic. Clear? Here, secondary means pseudo-achalasia. So this is also known as pseudo-achalasia. Pseudo-achalasia. Why it is known as secondary or pseudo-achalasia? Because it is secondary to, this is secondary to malignancy or Chagas disease. So this is secondary to malignancy. Clear? Or Chagas disease. So this is secondary to malignancy or Chagas disease. It's very easy to understand the clinical features of Achalasia Cardia. See, very easy. You can see here, this is the esophagus. Clear? And this is the stomach. What is the problem here? You can see that there is absence of LES relaxation. So LES is not relaxing. So whatever the food and whatever fluid patient has taken, everything is collected into esophagus. So what happens here? Whatever food and fluid patient has taken, everything is collected into the esophagus. Clear? So because of this absence of LES relaxation, what's the problem? Patient is having dysphagia. Second, since the food content is mainly collected into esophagus, it is not entering into stomach. So most of the times this patient is hungry. What is the second most common symptom? Weight loss. Clear? We discussed Zenker's diverticulum. Yes, in Zenker's diverticulum what happened? We discussed that there is a small diverticulum, and in that diverticulum what's the problem? There is collection of food, fluid. Right? So if you see, Zenker's diverticulum was only the trailer, and this Achalasia Cardia, it is a full movie, because in Zenker's, the food and fluid was collected only in the diverticulum. Here, food and fluid, it is collected in the whole esophagus. So whole esophagus is distended with food and fluid most of the times. Only little amount of food and fluid starts entering into stomach. So here, what's the problem? The most common symptom is dysphagia. So there are many similarities between Achalasia Cardia and Zenker's diverticulum. First, In Zenker's also, what was the most common symptom? Dysphagia. Here also, most common symptom, dysphagia. In Zenker's also, what was the problem? There was increased risk of aspiration. Because of that, pneumonitis. Because of that, lung abscess. So there also, most common complication was lung abscess. And in Achalasia Cardia also, what? Lung abscess. In Zenker's diverticulum also, because of chronic inflammation, there is increased risk of squamous cell carcinoma. In Achalasia Cardia also, what? Squamous cell carcinoma. So see, what are the clinical features we discussed here? Most common symptom in Achalasia Cardia. What is the most common symptom? And the most common symptom, dysphagia followed by weight loss. So here, the most common symptom, it is dysphagia. Dysphagia followed by weight loss. Clear? Now let me tell you what is the clinical clue or what is the clue given in the question related to Achalasia Cardia. If you see any other condition, in majority of other conditions, initially there is dysphagia to solids, followed by semi-solids, followed by liquids. This is the only condition where dysphagia is more to liquids. So in Achalasia Cardia, what's the problem? This is the clue given in the exam that here dysphagia is more to liquids. Dysphagia, it is more to liquids. Sometimes in exam they mention dysphagia equal to liquids and solids. So either they are going to mention dysphagia more to liquids or dysphagia equal to liquids and solids. Clear? This is the clue which is given in the exam. Related to achalasia, this is the clue. So obviously dysphagia will be more to liquids or almost equal to solids. Clear? It is characterized by triad. What is the triad? There is dysphagia, there is regurgitation, there is weight loss. So how to remember this triad? Mnemonic is DRA. What is the mnemonic? It is DRA. So you can see here, this is dysphagia, regurgitation and weight loss, right? Now see the complications. What are the complications? So we discussed that since there is collection of this food and fluid into esophagus, what happens? These patients are having high risk of aspiration. So what is the problem? In this case, there is high risk of aspiration. Clear? And because of this aspiration, what's the problem? There is pneumonitis. And because of pneumonitis, ultimately what patient develops? Lung abscess. Clear? So what is the most common complication? This is another question. In Achalasia Cardia, the most common complication, that is lung abscess. So here, most common complication. In patients of Achalasia Cardia, just like Zenker's diverticulum, the most common complication because of recurrent aspirations leading to pneumonitis, lung abscess. Clear? Lung abscess. Another question. In these cases, means in chronic cases, there is increased risk of squamous cell carcinoma. Why? Because there is chronic inflammation. So in these patients, there is increased risk of squamous cell carcinoma, just like Zenker's diverticulum. There is another question which is asked frequently. What is triple A syndrome? So triple A means achalasia, A means alacrima means absence of tears, and A means ACTH resistant adrenal insufficiency. So this is triple A syndrome. What is the other name? It is also known as L-Groove's disease. So what is the other name? This is also known as L-Groove's disease. Triple A syndrome. This is also known as L-Groove's disease. Clear? L-Groove's disease components are achalasia, alacrima and ACTH resistant adrenal insufficiency. There is a score used to assess the severity of symptoms and it is used to monitor the treatment outcome. What is the name? This is the latest update. The name is Achard score. So what is the name of this score? You have to remember, it's a potential question. Achard score. This is Achard score. So for Achalasia Cardia, this is Achard score. This is used to assess the severity of symptoms and used to monitor the treatment outcome. So used to assess severity of symptoms. It is used to assess the severity of symptoms. Clear? And monitor the treatment outcome. Achard score. Monitor treatment outcome. Clear? So name you have to remember, it is Achard score for Achalasia Cardia. Right? In the beginning only we discussed that what is the investigation of choice for diagnosis of motility disorders? Manometry. And if you see achalasia here, the gold standard investigation is high resolution manometry. So if you have to choose between these two, which one will you choose? HRM, that is high resolution manometry. So see, diagnosis Diagnosis of Achalasia Cardia. Clear? So the investigation of choice for diagnosis, it is manometry, and high resolution manometry, it's gold standard. This is manometry. And if you're talking about HRM, that is high resolution manometry. High resolution manometry, it is considered gold standard. This is gold standard for diagnosis. Clear? Now, what are the findings on manometry in patients of Achalasia Cardia? Now, first see the LES related findings. In Achalasia Cardia, there is absence of LES relaxation. So, there will be absence of LES relaxation. And because of absence of LES relaxation, there is increased LES pressure. So, LES related findings. First, here, there will be absence of LES relaxation. There is absence of LES relaxation. And since there is absence of LES relaxation, what is the problem? There will be increased LES pressure. So, here, there will be increased LES pressure. Now see, esophageal body related. In Achalasia Cardia, there is absence of peristalsis. And what happens? Food, fluid, swallowed air, everything is collected into esophagus. Because of this, what is going to happen? There is increased esophageal pressure. Increased intraesophageal pressure. So two findings. First, there is absence of esophageal peristalsis. There is absence of esophageal peristalsis. Clear? So absence of esophageal peristalsis. Clear? And second, what? There is increased intraesophageal pressure. So increased intraesophageal pressure. Why? Because whatever the food fluid patient has taken, even swallowed air, everything is collected into esophagus, and because of that, the pressure inside esophagus, it is going to rise. So these are the findings: absence of LES relaxation, increased LES pressure, absence of esophageal peristalsis, and increased intraesophageal pressure. So because of absence of LES relaxation on barium swallow, you can see there is abrupt tapering, and this abrupt tapering, it is looking like what? Bird beak or rat tail. So what are the names of appearances seen on barium swallow? It is also known as bird beak appearance, pencil tip appearance, rat tail appearance. So bird beak, pencil tip, rat tail appearance. In certain books, it is written that rat tail appearance is seen in carcinoma esophagus. Actually speaking, that is not rat tail appearance, that is rat tail filling defects. What kind of appearance? Imagine this patient is having this kind of malignancy. So if this kind of malignancy is there, so these patients are having this kind of rat tail filling defects. Clear? So rat tail filling defects, these are seen in carcinoma esophagus, but bird beak appearance, pencil tip appearance, rat tail appearance, these are seen in Achalasia Cardia. It's very easy to understand the management. What is the basic problem in Achalasia Cardia? LES is not relaxing. And you know that LES is smooth muscle. So by anything you are going to relax this smooth muscle, what happens? There will be improvement in symptoms. One thing. Second, if this is not relaxing, smooth muscle is not relaxing, sphincter is not relaxing, so you can go for forceful dilatation. And by causing this forceful dilatation, you are going to rupture the circular muscle fibers. So what we are doing actually in the drugs, we are going to give smooth muscle relaxant. So what are the drugs we are going to give? We are giving calcium channel blockers. We give calcium channel blockers. What are the other agents given? Nitrates. So we give calcium channel blockers, nitrates. You know that both of these are going to relax the smooth muscle. And there is another agent which can be given, that is 5-phosphodiesterase inhibitors. So it is 5-phosphodiesterase inhibitors. So we can give 5-phosphodiesterase inhibitors. Clear? These can be given. So these are the drugs which we can use: calcium channel blockers, we can use nitrates, we can use 5-phosphodiesterase inhibitors. Second is Botox injection. So botulinum injection, this is also going to improve symptom because it is going to relax the smooth muscle. So botulinum toxin injection, here we inject botulinum toxin injection. Third option, we go for dilatation. We have two types of dilatation. One is known as bougie dilatation. Second is balloon dilatation. What is bougie? Bougie is a metallic dilator. So we insert the metallic dilator and forcefully we dilate the sphincter. And balloon dilatation, Here we are going to insert a balloon in deflated state and then we inflate the balloon. So this is also known as pneumatic dilatation. So in dilatation we have two options. We can go for bougie, dilatation, bougie, or we can go for balloon dilatation. So it is bougie dilatation or balloon dilatation. This balloon dilatation is also known as what? Pneumatic dilatation. Now coming to the question, what is the treatment of choice? And the treatment of choice is the laparoscopic Heller's cardiomyotomy. That is the treatment of choice. In exam, sometimes the examiner is mentioning only Heller's operation. The complete name is laparoscopic. So this is laparoscopic Heller's cardiomyotomy. Clear? So here the term is self-explanatory. The myotomy should be extended till which part of stomach? So myotomy is extended till cardia or at least 1 centimeter of stomach. So this is cardiomyotomy. So myotomy is extended till cardia. It is extended till cardia or at least 1 centimeter of stomach. Extended to 1 centimeter of stomach. Clear? Now the problem. Whenever patient is having absence of LES relaxation and you are performing this cardiomyotomy, what will happen? The sphincter is open and these patients are prone to develop GERD. So after performing Heller's cardiomyotomy, to reduce the risk of gastroesophageal reflux disease, we go for fundoplication also. Now you tell me which type of fundoplication should be done, complete or partial? So here we go for partial fundoplication, and you know most commonly performed partial fundoplication, that is Dore and Toupet. So after this Heller's cardiomyotomy, we go for partial fundoplication. So after that partial fundoplication is done. So we perform partial fundoplication. So what are the options for this partial fundoplication? One is Dore. We can go for Dore fundoplication or we can go for Toupet. So the fundoplications done. These are partial, Dore and Toupet fundoplication.